I agree with Dr. Dinakaran that CIMT is a surrogate marker of the vascular disease and which also correlates with the cardiovascular disease in the other arterial territories. We did the initial study in 2004 where he has quoted the Indian normals of CIMT. The Indian normals of CIMT, we did this study. Subsequently, we went ahead in this study and found that the arterial wall gets affected by three mechanisms in chronic kidney disease. One is by oxidative stress, the second is by endothelial dysfunction, the third is by chronic inflammation. So we studied the factors that are depicting the individual inserts and then we correlated again with these factors the CIMT. So we found a correlation. So what exactly is happening is even before the calcium and phosphate is getting deposited, the vessel is sufficiently damaged in carotid artery. So which signifies that the coronary arteries are also significantly damaged by that time. So it is like an epiphenomena. Calcium phosphate deposition is just an apparent thing on the surface, but inside the blood vessel has already been very much damaged.
So that is more the reason that we should look for CIMT and not statistical results with calcium, phosphorus or CRP.
No, you should look for the injuring factors, endothelial dysfunction, oxidative stress and inflammation.
No, high CRP we have done in this study. It did not correlate. I only took a few facts. I have left off some of the others because all were negative. It did not correlate.
No, I agree. But all the three put together they correlate.
No, that's what I said. There was some semblance of a correlation with phosphate raise. There was some semblance of a correlation with calcium and phosphorus product, but the observation was not statistically significant.
That's what I'm saying. See,
I understand your point. Even before these abnormalities set in, the vascular damage has already been done due to some other factors.
That's not what I want to tell you. When you do a statistical analysis, individually the markers of endothelial dysfunction may not correlate with CIMT. But if you take all the three together, they correlate with CIMT. So when you do a statistical analysis for these three factors, you should do like that so that you can get a correlation.
Actually, in this study, because I gave the whole thing to a statistician in a teaching institution, he said all factors put together also, the correlation was not marked. That was his inference.
Thanks for the observation. Influence the cardiovascular outcome because there are other factors beyond ischemic heart disease which is going to affect, which is going to add to the cardiovascular mortality. That's one. And second thing is the aspect of carotid intimate medial thickness versus vascular calcification. These are two different entities. We will discuss about that in the evening symposium. So intimal thickness is only a different pathophysiological process when compared to calcium depositions in the vessel, which is predominantly a medial disease. So these two factors may be totally a different phenomenon.
But which of these two correlates better with the cardiovascular mortality?
Both. Right.
That's why we try to correlate both.
Intimal abnormality is more of atherosclerotic process, whereas the medial calcification is more of a level connected of the other aspects.
Thank you.
Thank you, Dr. Dinakaran. We will move on to the next paper.
Next paper is drug fibers
My topic is drug fibers and ADA, the part of nephrology, addressed by the college of hospital setting. Introduction. As you know, drug fibers is caused by potential Sugamushi due to the bite of the respective northern tropical bite, and there is a re-emergence of infection in South India. And presentation usually with fever 7 to 10 days after the bite, with a classical SR on the side of the bite. And AKA is a common association. And there is a good response to doxycycline, and early treatment has a decreases the morbidity incidence being 9.7%. The sex distribution showed males to comprise of 13, females number of 16, and females were 3 patients. The age distribution showed age group between 41 to 50 years comprising of 6 patients and 31 to 40 years comprising of 4 patients. A similar analysis showed apart from fever, myalgia, headache, jaundice and oliguria were the common presenting symptoms. On examination, we were able to identify an SR in 7 to 16 patients, which comprises of 44% of the study group. This is a picture of an SR seen in one of our patients. The lab profile revealed leukocytosis in 50% of the patients, thrombocytopenia in 62.5%, and hyperbilirubinemia and elevated liver enzymes were seen in 75% of the study group. This is a profile of the renal failure seen in our patients. As you can see, acute stage 1 comprised of 2 patients, stage 2, 4, and stage 3 had 10 patients. Hemodialysis was required in 10 of our patients, which comprises of 62.5% of the study group. The outcomes showed that 11 patients survived and there was mortality in 5 patients. We tried to study the various prognostic factors which could have an effect on mortality, and from our study we found that a serum level of more than 3 mg per deciliter had a significant correlation with mortality. Also, thrombocytopenia with a count of less than 1 lakh also had a significant correlation with mortality. Lung involvement in the form of ARDS is also shown to have a significant correlation with mortality. The sera of our patients were tested for IgG antibodies to Ornithia suzuki using the laser kit, and a 56 kilodalton recombinant antigen of this Suzuki machine was used, and the sensitivity and specificity of our test was above 90%. We were able to do a renal biopsy in one patient with Staphylococcus aureus and showed the presence of an acute tubular decision nephritis. All our patients were treated with doxycycline at a dose of 100 mg twice daily for a period of 7 days. A review of literature showed a study that in CNC method titled "Scrub Typhus among hospitalized patients with tubular illness in South India," and this was published in the Journal of Infection in January 2006. In this study, the incidence of renal failure was found to be 12%, and also an SR was seen in 8% of the study population. The level of serum bilirubin was increased in 75% of our patients compared to only 30% in their study. The mortality rate in our study was 31% versus 14% in their study. A reason for this increased mortality in our study could be that while we included only patients with renal failure, the CMC study group had only a 12% incidence of renal failure in their study. A comparison of predictors of mortality in their study also showed serum creatinine presentation to be a significant determinant of mortality, whereas thrombocytopenia was significant in our study. In their study, did not show any statistical significance. Transaminase levels, serum bilirubin, and leukocytosis had no correlation in both studies. So to conclude, scrub typhus is an important difficult diagnosis for fever with AKI. An incidence of AKI in scrub typhus is around 9.7%. A patient presenting with a fever, an scar, leukocytosis, thrombocytopenia, hyperbilirubinemia, and increased liver enzymes favors the diagnosis of scrub typhus. And in our study, dialysis-required renal failure was seen in 62.5% of the study, and the mortality rate was 31%. The severity of renal failure as presentation and lung involvement helps in predicting mortality. Thank you.
Let's talk about developing scrub typhus. Is there any kind of occupational hazard developing by?
Yes. Those patients affected who have contact with the possibility of being within by the mind, those who are manual laborers or farmers have a higher risk of developing scrub typhus.
Knowledge that what we need to do a bioinfluence test to prove the use of typhus. Is it now not being practiced or is it?
As per the review of literature, the bioinfluence test lacks sensitivity and specificity, and so they prefer to use the enzyme that has more sensitivity
And there are no questions now.